afternoon, everybody, and welcome to the second in our Dementia and Palliative Care series. And for those of you who don't know, we had a summit in Wangaratta last year, open to the aged care workforce in the Hume region, where we invited people who had a lot of passion around providing palliative care for people with a dementia diagnosis in the aged care setting. And we learned all about how we can provide better support and care. We asked as part of that conference for people to submit questions to us during the day and beforehand, and we have lots of amazing questions, and sadly we didn't get to them all during the day. So what we're doing today is going through some of the questions that we never got around to asking. Today, to help me with that, is Tiffany Button. She works with Palliative Care Victoria. Welcome, Tiffany. And just explain to everybody what you do in the role if they haven't met you already, because you come to our conferences, so you might have met Tiffany already, but tell everyone what you do with Palliative Care Victoria.
Thank you, Sam. It is nice to see everyone. My role in Palliative Care Victoria is quite unique. I'm a nurse by background, but I hold the hat as an aged care project officer. And within this space, essentially it's a lot of different work supporting the work of palliative care and aged care. So it can be supporting conferences like the one held in Hume. It can be working with the government on an advocacy front and taking feedback from the sector. It can also be on a clinical front and taking questions from the community and helping them navigate the system. So jack of trades.
Thank you so much. And you can tell now why we ask Tiffany and Palliative Care Victoria to come to our conferences, because there's just so much knowledge out there, and it's for you guys to ask questions. So I have 5 questions for Tiffany today, and she knows which questions I'm asking beforehand. I'm not that mean. So we'll just go through the questions one by one and have a little chat about it. So if you're ready, Tiffany, your first question for this afternoon is, what is the difference between palliative care and end-of-life care?
A good question, and the two often get interchanged, but they're not the same thing. So easiest way to think of it is palliative care is the whole timeline, and the end-of-life care is the meaty bit at the end. So palliative care typically starts for a person on the day of diagnosis, and it can be a diagnosis of any life-limiting condition or any condition where you are likely to die because of the disease and not a natural death. End of life, by definition, they say it's the last 12 months, but it can be the last 12 months, the last couple of months, the last couple of days, weeks, hours. It's essentially that significant turning point in your palliative care journey where you have left curative treatment behind and you are now focusing on comfort care and supportive care to provide you the best quality of life and support you through active dying.
Thank you. That's great. I actually really like that description. It's often nice for people to hear people explain it too, because often people get asked by family members within residential aged care. So like hearing lots of people explain this concept of the difference between palliative care and end-of-life care is often really, really helpful. Often I think people in the community find the phrase palliative care quite intimidating and scary. So the more we talk about it, the easier it is and the less scary it seems. I have a second question for you. When a nursing home resident who is in high care with dementia, when are they officially palliative? At what point does someone become palliative, especially if they have a dementia diagnosis?
That is a good question. So the Royal Commission in 2018 actually looked at palliative care and aged care, and one of the strongest statements they said is that palliative care is core business for aged care. And this is because aged care typically is your last residence before you die. This does not mean that everyone is palliative, but it does mean we typically treat everyone through a palliative approach. The priority in the last chapter of anyone's life is not to prolong life, because that will naturally occur on its own timeline. It's to keep people comfortable you can get. In terms of when we would say a person is palliative, I think it's referring more to if a person in the facility is living with a complex condition that's not curative, so dementia, heart failure, can be types of cancer. It can actually even just be age-related frailty. That palliative approach commences from day one. The moment you assess it and you pick it up on the paperwork, you've already determined that you're not going to be able to prolong this person's life with this condition. So the focus is going to be keeping them comfortable. When we tend to start talking to family about end-of-life considerations, may be different for everyone. I like to take the approach that if we normalise it, if we talk to everyone from the day they hit the front door and say, we talk to every family member and every resident about this because it's a natural part of life. We would like to know what you would want if your health declined or if you were approaching death. Then as you start having those more frequent episodes where your health changes, it becomes less of a startling thought to talk about. Families often have the worst experience when they feel blindsided, when someone has been living in a service for many years and they thought everything was tickety-boo, and then suddenly they're being told mum or dad needs end-of-life care. What's typically happened over that timeline, though, is mum's no longer walking to the day room, mum's no longer eating meals independently, they may be requiring more assistance with showering, particularly those last weeks to days. They may not be going out to the day room as much. They may be sleeping the majority of the day. They may be starting to have more recurrent infections, and they may be getting less responsive to the antibiotics or any treatment being given. These are all those subtle turning points of health declining. And that's when we start talking about the end-of-life care that we're going to provide as part of that palliative approach.
Thank you. Another really beautiful way of talking it through too there. I might include in the show notes the LDAC Talking with Families toolkit, because the things that Tiffany's explaining, those little moments in time, there are some really lovely diagrams in the toolkit that can really help you if you're a visual person to see what that looks like. So that's a great thing to have a little think about. Thank you. All right, we're getting through these questions. The third question for you is, how do you discuss dementia with a resident who has early onset dementia in their 60s? Do they know they have dementia?
I think it doesn't really matter if it's early onset in your 60s or if it's a later onset Alzheimer's in your 90s. You are talking to a person, and you are talking to a person about a medical condition. Early in that condition, you will find a person is more cognitively able to have the conversation, retain the information, and share what they feel or what their opinions are about the diagnosis. And I think particularly if you're identifying this diagnosis quite early in someone's trajectory, you should put as much focus on planning and get as much insight from them as possible on what do they value and what do they want you to retain as this changes. It can be very tricky for young onset dementia, because from a lot of the literature we have around young onset dementia happening earlier in life, it's much more complex in a social front. So being younger, people are typically or children under their care, they may be still working, they may be still driving, they may be still active in the community, and receiving this diagnosis factors in more than just age-related decline. It becomes a grieving process on a lot of the things that are currently active in their life, knowing they won't get to experience them at the same time as their peers. So when we're talking to people about their diagnosis, you don't sugarcoat any information. You talk to people quite honestly about what is going on and what to expect. But I think it's taking into consideration those other factors that are personal to the person. So it's contextual. You don't jump straight to talking about your end-of-life care. You try and meet someone's immediate needs. Do you have a preference on where you want to live? If behaviour changed in this regard, what is an acceptable level of care? Power of attorney, medical treatment decision makers? Do you have a plan for your finances in terms of the kids still in school? How will the income for the house still occur? These are very practical considerations that are normally relevant to this group. When someone is in the later stages, you cannot black or white say when a person has more lucid moments or not. Typically, it's not a hard and fast timeline. There will be better days, there will be worse days. I think the most important part is always treat the person as if it's a good day and be prepared for the bad ones. Knowing if a person is aware of their dementia or not, does it help? Does it help you? I think when you're having conversations, it's more about being able to identify what they're able to take on at that point and how you can meet their immediate needs.
Thank you. Another fabulous answer. So helpful. Thank you. No, this is good. And I really enjoy the fact that we've had these questions from actual workers. And so these are real things that are going through people's minds. So it's just so nice to have a bit of time to chat about it. Fourth question. How can we ensure that the preferences and wishes of individuals with dementia, even as their capacity to communicate directly diminishes, are honoured and respected in their end-of-life care decisions?
I like this question because I think in a perfect world, everyone would have a very robust advanced care plan and everyone's written down exactly what they want in later life and they know exactly how they're going to feel and experience things. And my life would be much simpler. But the reality is we're human and you cannot predict many things. So when you have these situations where you're trying to plan care for someone who maybe hasn't clearly said what they would want, you have to be a bit creative. And this can mean talking to friends or family. It could mean talking to aunties or uncles who may have had these close conversations. Many families have had these conversations at moments they don't remember because it could have been after the death of someone else in the family or a close friend. It could have been a flippant statement they said visiting someone from hospital. It could have been a conversation with a GP or a care provider. It could have been just reflecting on how they've previously encountered health challenges. So if the person has recently been in hospital or they'd had a very difficult experience trying to engage with a GP, these are things that you'd be reflecting on. In terms of putting it on paper, that's a very important part. And I think that this is where, sorry, Sam, I'm going to sneeze.
You're fine. Bless you.
Sorry, Rose.
I'll tell her. It's 53 minutes sneeze.
Oh dear. In terms of putting it on paper, I think it's not so prudent what paper you put it on. So particularly once someone has lost capacity, they've lost the ability to legally complete an advanced care directive. There are beautiful tools that you can use for advanced care planning to actually identify a person's wishes or preferences. And the beautiful part of these documents is they don't need to be signed by doctors and they don't need to be completed by the person when they're, fully cognizant. You can actually just complete these on behalf of someone as a nurse, as a relative, as a friend. And they're basically statements that will help create a picture of who the person is. And then this picture is then used by clinicians when they have to make judgment calls on what treatment to offer. So, for instance, nurses may find that a resident hates going into the shower, that they get very distressed whenever this occurs. And the staff are starting to get concerned that if we don't shower her, her skin will break down and we'll be in trouble because she'll have wounds and that will be our failure of duty of care. This can actually change when you start reflecting on the person. The person doesn't like showering. Turns out they lived on a farm most of their life. They never had access to showers. They were always cold. So they now find them very traumatic. In terms of us then trying to develop a care plan for this person, it could be we don't give showers. Maybe we just give bed baths. Maybe we just have a basin of warm water at the sink and we help support them with wet flannels and tend to their personal care that way. It's meeting the person where they're at and taking into context who they are and what their values are and using them to support their current preferences and choices.
Thank you. I will add to the show notes the documents that Tiffany's referring to, or the examples given in the Advanced Care Planning Australia website, because there are multiple versions, but there are versions of what I believe the person's wishes to be documents there. So we'll get those linked in for you. Have a look at those because they're such good tools and resources.
Another good one, if you do have someone who has fluctuating capacity and they're not in a position to do an advanced care directive, you can still do the discussion starters that Palliative Care Australia developed. So the what matters most for someone, particularly if they're having a good day, you sit down and it's quite a beautiful workbook to just go through, and it's just guiding statements. And it's still quite meaningful what people can come out with.
Wow, I will definitely add that too. That is a good point. Thank you. Last question, Tiffany. So, what is the most important support for a person with dementia at the end of life?
Oh, I love this question. It's a very difficult one to answer because the best support you give a person is the support that they need. It's very person dependent. It's not a matter of every person dying of dementia should receive X, Y, Z. It's knowing what's important to the person and what worries the person and trying to relieve those things. It could be their worry about their family. It could be the distress their family are going through, in which case the greatest support you can give them is just reassurance and support for their family as they're dying. Some people are terrified of pain. So having a really well-structured, comprehensive pain management plan can be a very helpful thing, and that's the crucial support they need. Some people have experienced existential distress. Some people have a fear of dying. Some people don't want to be alone, in which case it can be providing company. And particularly in the palliative care world, we actually have volunteers that will sit with people as they're in those days and weeks and months and hours to provide them that solace. It's very person dependent. I think as long as you're honouring who that person is and you're remembering they're not a diagnosis, they're a person, they lived a life, they may have had children, they may have travelled the world, they may have been a high-flying corporate in their working life. It's remembering that that person is still in there. They may be non-verbal, they may have flattened expressions, they may have irrational behaviours, but beneath that is still who they were. And I think when you can tap in and really provide dignity and honour that, you'll get a better outcome in terms of the care that you provide. Still came up.
I did. It still came up. That's okay. Final statements, Tiffany. Is there anything you wanted to share with the aged care workforce, either around the dementia and palliative care world, or even maybe should they want some further information on how Palliative Care Victoria can support them with any questions they have, where they would go, and if there's any particular documents that you recommend?
Well, that's a good one. Got to think about it because there's a few things that I think are worth that are helpful here. So I think the first thing is planning ahead is very helpful, particularly because we are now living with a very different aged care setup. Access to care has more steps than it previously had, and there are services that are still adjusting on how to provide the care a person needs. So I think the earlier families actually plan for those steps is very helpful. This can mean, for instance, someone who wants to stay at home. Is the home accessible? Do you have access? If the person's mobility decrease, will they be able to get into the house, into the bathroom, into their bedroom? It can mean if you need additional assistance with care, have you done means testing with Services Australia? Have you figured out that you live in an area that has some home care providers? Have you sussed out how much that may cost in co-contributions and really spoken about what this will look like in practical terms? I think there's also a big effort that we need to make in upskilling our knowledge in dementia. So the Equipped program out of the University of Tassie is a fantastic resource for people working in aged care to upskill their knowledge in dementia, and it's free. There are so many resources out there for free. Knowing what to expect in those advanced stages of dementia, I think we're very good as a community of talking about how we can improve our brain health, and we can do preventative measures, which I highly recommend. But I think we have less of an understanding of what it looks like when a person is dying with dementia. And I think this becomes a barrier then to us being able to share that with families. So I will share some resources with Sam that she can pop in the notes, but there are certainly some fantastic guides that talk about what it looks like for a person when they have dementia and they are dying, and how you can prepare families for what to expect.
Lovely. Thank you so much for your time today, Tiffany.
Okay.
It's always just such a pleasure to chat with you. If you've got any further questions for Tiffany specifically, I'm sure she wouldn't mind if you pass them through to me. I can send them through to her, and we can connect you. All right. Well, we'll see you again soon. Thank you so much.
Thank you.